staying healthy, staying sexy, staying young is what living life is all about. And if you have doctors that have proven treatments that keep people young and healthy so they don't get sick, um, you want people to know about these treatments and that they exist.
This episode is brought to you by Gainswave. Gainswave is a treatment done at your doctor's office to optimize erection quality without the need of Viagra, Cialis. It's non-surgical, there's no needles, and it has an amazing success rate. To find a Gainswave provider, go to gainswave.com. That's GAINSWAVE.com. This is Mark L. White with Health Hacks, and today we have Dr. Carl Walker, urologist, also known as a mancologist, with us. Thank you so much. I really appreciate you taking the time out to talk to us today about what you see going on with urology. And really, I'd like to learn more about what you've seen with COVID and erectile dysfunction. So let's take it away.
Okay. Well, thank you for having me, and great to be able to share my experience and whatever questions I can answer that's going to be edifying. So yeah, it's been an interesting year plus. I think that as we get a little bit more back to normalcy, I think everyone's had a little bit of ability to kind of reset, reprioritize, and obviously, ED has always been a big issue, but now we're seeing some recent studies that have come out showing a correlation with COVID and ED. So one other knock against man's ability to perform, is on the horizon here. So I think we just gotta gear up and try to fight the process best we can by improving health in general and boosting the immune system and doing all the right things to keep the body healthy.
I think, like, if you want these guys to get their vaccine and you start to tell them about this might actually affect your performance in the bedroom, you'll probably see a lot more guys going out there saying, sign me up for that.
Right. Yes.
Now you were a urologist in Los Angeles, but I understand you recently moved.
So actually, I was in San Diego, Encinitas, and
San Diego, okay.
and also Temecula area. So I'm actually in transition. I'm going to be working in Spokane with a group, Spokane Urology, and living in Coeur d'Alene, just across the state line in Idaho. So that's going to be happening within the next several weeks here. So I'm just kind of ramping closing down my practice there and ramping up for my new location.
Completely different market, Western Washington or Eastern Washington than Southern California.
Definitely. But beautiful area, and kind of a great location with lots of great outdoor activity and fresh air, and good way to kind of stay active and stay healthy.
Why did you choose to go into urology?
So interestingly, I had planned on going into cardiac surgery in medical school, and I would say that my key mentor during medical school was a urologist. He was the chairman of the urology department at the VA in La Jolla. He was a retired Navy captain, just kind of a character, but was really motivating, and someone who became my key mentor. And I said, well, I want to do what he does. And so I kind of made that switch during my third year of medical school, that I decided I wanted to do urology.
And when we think of urologists, we think of just guys that go in there for just the penis, but there's a lot more going on. And I know you do a lot more holistic treatments than most urologists.
Yes. So I would say that over the past 4 to 5 years, I've really introduced a more holistic, integrative approach to my urology practice. A lot of that has to do with, I think, my patients would have questions about different supplements that they were taking, and should they take them? Are they any good? And I didn't have a lot of knowledge base to recommend one way or the other. So I felt a little bit inefficient at helping them along that course. I always knew that healthy lifestyle was important to overall health, but I didn't have a lot of knowledge there. So um, I had made some contact with colleagues of mine that were naturopathic doctors, and there really is kind of a real difference in our training. Both very good medical training, but we both are on kind of different sides, and we don't really, you know, shake hands in the middle to see where can we benefit our patients with both of our knowledge bases. And so I think there's benefit on both sides. I think that a traditional medicine, or what we call allopathic medicine, does great for acute conditions, and but I think the more holistic or integrative approach has a lot of benefit for the more chronic conditions. And I would say that a lot of urologic conditions kind of bridge the gap. If someone has an acute kidney stone and they're in a lot of pain, you kind of have to jump in and unobstruct the stone and take care of them. If someone has a more chronic condition, I would actually put ED in that situation, because it's usually very progressive, and it doesn't just go away overnight. That's more of a chronic condition. So I think there's a lot of potential benefit from that integrative approach.
So what can a younger guy do, diet, lifestyle, to prevent erectile dysfunction?
Yeah, so good question. I think that when we look at any disease process, or you kind of compare someone who's 18 to someone who's 80, and a lot of the things that you wouldn't even think about at age 18, but they're kind of your primary thoughts at age 80, is it's a blood flow issue. It's oxygenated tissue, and so your skin elasticity, your muscle strength, your energy level, as the as the body starts to kind of break down and the cellular repair isn't as optimal as it used to be, a lot of that has to do with poor oxygenation, and that comes from good blood flow. So how do we maintain good blood flow? Well, what tends to happen to the vessels, we all know about coronary artery disease. That's you know the big concern. Anybody with chest pain or blockage of an artery, we know that they're not getting good blood flow to the heart, and so they may run the risk of damaging their heart muscle permanently. But that doesn't happen overnight. That's a very gradual process that occurs when one, with aging, but two, with poor diet. If you're eating a lot of trans fats, if you're eating a lot of simple carbs, if you're not having your several helpings of vegetables a day, your good fibers, and if you're very sedentary, if you're not active, then you're going to put yourself in a position where you're more likely to have decline in your vascularity, and the effects are going to be in every part of your body.
So you usually see like a guy who's eating poorly, he starts to suffer the effects of ED at a younger age. Obesity is a factor. What else should they be doing? And do you see a lot of younger guys coming to you who are otherwise healthy, who have suffered from ED?
Definitely, yeah, and it's always multifactorial. And so I think that one of the things that we've done as we've modified our approach to all men coming in with ED, you want to have somewhat of a standard approach where you are able to rule out any of the main risk factors. And so we'll get a comprehensive blood panel. We want to look at the blood count, lipid panel, a testosterone panel. If someone comes in like a younger guy with ED, obviously we want to make sure they don't have significant hypotestosteronism, because that's a relatively easy fix by resupplementing their testosterone level. Sometimes you can give testosterone in and of itself, or just with HCG, depending on the age of the patient, to kind of stimulate the gonads to produce the testosterone. And obviously, you don't want to miss an opportunity to make an easy fix with testosterone replacement. But obviously, if that patient has other significant risk factors if they have super elevated cholesterol and triglycerides, and you can kind of assume that they're going to have some underlying cardiac disease. You want to maybe employ the help of a cardiologist so that they can get on track. So ideally, you want to guide that person along the path of better health. And if you just examine them and they have, like a BMI of 35, if they have, they're significantly obese, if they have, elevated lipids, if they have other risk factors like, hypothyroidism, you want to recognize those and address those issues.
Does low testosterone, if you optimize testosterone, does that usually solve the blood flow issue, or are these two completely separate issues?
They're related, but they're not a one-to-one. So someone with a very normal range testosterone can still have ED. So there's multiple factors that can cause ED, but testosterone is one of those factors that, specifically if it's in a younger patient, having a much lower testosterone that you would think, sometimes optimizing that level or normalizing that level will remedy that problem. So it's again, you can't just look at it in isolation. That I think that's the problem with a lot of our health issues. We kind of put them in a box and say, okay, here's your symptom, take this medication for this symptom. It's like, what you don't want to do. So if a patient goes to the doctor every year and they have an elevated glucose level, and you see them every year, and then you just kind of watch them progress into diabetes and go, okay, now you have diabetes, let's put you on metformin. So, well, what could we have done 5 years ago when you started to come in and you were only pre-diabetic? What could we have done to turn that around so that your glucose is normal? You wouldn't have to start medications and ultimately have to be on insulin. So what can we do when we recognize the potential problem to reverse it or correct it?
Unfortunately, though, I think a lot of guys wait until they sense a problem before seeing a doctor. How do we get these guys earlier so there isn't a doctor later, other than just letting them know what's going on?
Right. Well, that's always tough, because I think men are much less likely to seek healthcare than women, and so we're already behind the 8 ball. Kind of the mindset is, work hard, drive hard till I'm 65, and then I'll retire, and then I'll take care of myself. It's like, well, a lot of bad things can happen in that time frame. So I think the nice thing about what a program that we've initiated in our clinic is what we call lifestyle medication or lifestyle medicine, where we're not trying to make anybody make you know uh, huge changes. It's not like a diet. It's basically making smart choices. So you're just kind of adjusting the needle in the right direction. So when you go to the grocery store and you're going to shop for the food for the week, shop the outside aisles. Don't stay in the center aisles where all the processed food is. When you go out to your favorite restaurant to eat, decide what you're going to order before you get there, so you're not hijacked by whatever's passing on the waitress's tray. And so you can start making smart choices about what you're eating, how much you're eating, before you're put in the situation where, well, I'm really hungry, what do I do now? So that would be the thing for a diet or kind of a nutrition plan. As far as exercise, I think it's just a matter of, most guys, if they have the energy level, they want to exercise. It's just that they don't really know what to do. Most guys are going to do the same kind of workout regimen they did when they were playing high school football or something. So your body changes, and so you need to be on a different regimen. And so we try to educate our patients on plugging in with a personal trainer, a physiatrist, who can look at their limitations, their balance, their strength level, and design a plan that works for them, so that they're actually helping themselves build lean muscle mass and kind of lose that mid circumference waist level.
Now, I know in erectile dysfunction, it's very complicated, but you see a lot of it could be psychological. How do you rule out the psychological components? And are you seeing a lot of guys with porn addictions or sexual dysfunction that's caused in the brain?
Yeah, so good point. I think porn addiction definitely plays a role. I would say probably more so in my 18 to 25-year-old group. So when I see guys coming in and they're in that young age group and they don't have any other medical conditions, the key thing is just having an open discussion. By the time the men make it to the urologist's office, I think they're ready for help. And I just kind of assure them, it's like, you're not going to tell me anything I haven't heard before. And I think that's the case for most urologists. We're never shocked about what we hear. And so we can definitely lend a supportive ear. And I think that we all need to have in our back pocket a good sex therapist or family marriage therapist that we can plug our patients in with if we don't suspect that our measures for treating ED are going to be effective, or at least we can work together to try to help the patient. But it's really just all about open communication.
Okay, no, that's really interesting. Now, for the last 25 years, everybody's talking about Viagra and Cialis, the PDI5 inhibitors, and now you're seeing Get Roman and subscription service. So guys are like, I'm not going to change my lifestyle. I'll just pop a pill whenever I want to have sex.
Great.
Is that a problem? Do you see that as being, are there side effects to Viagra, Cialis?
So I would say that there are not a lot of side effects to the PD5 inhibitors. I would say it's a pretty safe group. It's a safe grouping of medications. Now, obviously, if a patient has significant cardiac disease, and specifically if they're taking nitrogen products, then it can cause an unsafe drop in blood pressure. So that's a contraindication if they're taking nitrate products. But otherwise, it's a pretty safe medication group. The problem is that it's kind of a band-aid approach in that it's allowing the cyclic GMP, which is allows the blood vessels to stay dilated in the penile vasculature. So it does its job for a period of time, but just like anything, at some point, when the vascularity to the penis continues to decline, that's why you need the Viagra in the first place, it's going to stop working. You're going to have to up the dose, and you're not going to get the same effect, or at some point it just won't work at all, and you're going to be like, "Whoa, what I do now?" And again, the approach would be, realizing that I have a problem. The fact that I need Viagra is suggestive of a disease process. What can I do to kind of reverse that? And that's where, again, the lifestyle medicine program is, I think, a key benefit. So you have an opportunity as urologists to educate that patient on lifestyle changes. And again, we're not talking like, major diets like Jenny Craig or, Weight Watchers, which are definitely effective. But I would say that most people that do it, after they're done with the diet and they lose the weight, they typically will gain the weight back, and they'll kind of do that yo-yo effect where they'll go on it, lose the weight, go back off it, go back on it again. And what you want to prevent is that yo-yo effect. But with lifestyle changes, what you're doing is you're in control and you're making smart choices so that you're not doing the yo-yo effect. You're eating healthier, you're doing your exercise regimen, so you're not bouncing up and down like a beach ball.
I find a lot of urologists tend to be more on the conservative side. They're more, especially traditional insurance-based group practices. Now we have a lot of new treatments. Gainswave, obviously. There's a lot with regenerative medicines. Like, what do you see as some of the most effective treatments for that? The fix.
Yeah. So again, I think regenerative therapies in general are very exciting field, and I think that unfortunately the U.S. is probably at the back of the bus in regards to how they progressed in Europe and Asian countries with regenerative therapies.
Why do you think that is, by the way? Because it's always a theme, and I've heard different opinions. I'd like to hear yours.
So I'm not going to blame the FDA, but I guess I am. I think that they have a role in the processing of new techniques and medications, and they have their own priority list of what gets their attention, and this has just not gotten their attention in a timely fashion. So there's been, FDA protocols that have been presented over the past several years, but there's just not a lot of quick action on their approval of regenerative therapies. So they tend to be more of a um, police force than an actual facilitator of new techniques. So again, the positive is we have a very safe drug supply here in the U.S. Probably safer than anywhere else. On the other hand, we're definitely stifled when it comes to newer therapies that have been out and used in other parts of the world with good efficacy.
I like what you said about the police. It's like the FDA is more interested in protecting pharmaceutical companies than they are of coming up with novel techniques.
Right.
But you hear a lot with the P shot, for example, and using PRP to rejuvenate the penis, exciting things with stem cells. Are you incorporating any of that into your practice?
Yes, I am. I've been doing, well, in addition to GainsWave, I've been doing, PRP shots for the past 4 or 5 years. I usually will combine the PRP shot with GainsWave technique, and so we have a protocol that we do, for our patients. I'll have a few patients who only want the GainsWave or only want the PRP shot, but I would say that 90% of the time, 95% of the time, we're combining both modalities. Um, I have been exploring exosome therapy, and I think that's a very exciting area. Again, it's a fairly new uh, technique in the world of ED, but exosome therapy is, I guess, kind of a hot topic right now, and so that's definitely something that I would be um, uh, interested in providing for my patients. I have done biologic allografts for patients with ED, and I I kind of base that. I kind of allow the patients to kind of direct that because of the increased cost, and I don't think there's a lot of science, or not enough science for me to kind of promote that as the end all be all. But if patients have done the research and they come to me and they want it, we'll go ahead and order that and provide that for them.
That's the allografts. Tell me more.
Okay, so that'd be the stem cell products or the Wharton's jelly, so which provides a basically a scaffolding uh, process where you're giving the undifferentiated cells that will release growth factors and promote improvement in uh, new blood, new blood vessel growth in the penis, which is kind of where we're at with ED. It's like, so we're really relying on a very small vessel on the left and the right side of the penis called the cavernosal artery. Um, they're very small vessels. They're about you know, you know, 5 to 7 millimeters in diameter, and that's all you get. It's not like the heart where you get collaterals if you get some heart damage, and the vessels will kind of regrow to kind of resurface the heart diameter. That doesn't happen in the penis. Once those vessels have become damaged, that's basically it. So the goal with any treatment that we give for erectile dysfunction is to try to improve the blood flow through those cavernosal arteries, and so where regenerative therapies have, I think, the best benefit is, so if you take a Viagra tablet, you got to take that Viagra tablet every time you want to have sex. What if you could do something now that within the next 2 to 3 months would allow you to perform spontaneously like you did several years previously? That would be great. And that's what GainsWave allows, and that's what other regenerative therapies like stem cell / biologic allografts and potentially exosomes will, and the PRP shot. That's where we're standing right now, determining what are the best protocols, what's the best sequencing, and specifically what is, how do we select our patients appropriately? Because at the end of the day, it all comes down to appropriate patient selection to determine, who's going to benefit, who's not going to benefit.
What is the best type of patient for Gainswave? Like what is the sweet spot? And who wouldn't Gainswave benefit?
Ask me that last question, the last part of the question. I didn't hear that very last
Yeah.
part of the question.
Who would benefit the most from Gainswave, and which type of patient would not benefit so much?
Okay, so who would not benefit? So my classic patient who would come in and say, "Hey, I've researched Gainswave, and I want to do it," would be a gentleman, say, that had prostate cancer and had a prostatectomy for his prostate cancer, but they didn't spare the nerves, and he never got any erections whatsoever after his prostate surgery. That gentleman would likely not be a good candidate for Gainswave because there's not enough neural tissue to stimulate the cavernosal vessels to allow any success. So it would be that would be someone I would discourage from doing that therapy. So we have our patients always fill out a SHIM, or Sexual Health Inventory for Men, or the IIEF, International Erectile Function Index. And so they'll, if they're scoring, in the mid-teens to lower 20s, then they're definitely a good candidate for Gainswave. If they're scoring in the single digits, they're probably not a good candidate. Not that they would never be a good candidate, but at this point, they're not a good candidate.
Are there any treatments that would help men with severe ED that are out there?
Yeah, so I mean, we have standard therapies that have been around for decades. We have the trimix, the injection, intracavernosal injection of agents, prostaglandin and other vasodilator agents, and those actually work quite well. It's just a matter of kind of appropriate teaching the patient how to titrate the dose appropriately, how to get the desired result. You don't want it to last too long, but long enough. And so there's a little bit of working with the patient so they understand the science behind it and where they could potentially cause more harm than good. But once you get to that point, again, patient selection, that can work quite well. And sometimes those patients, if they're using the therapy regularly, and then they may start to get some spontaneity on their own. They might start waking up with morning erections. I'm a big proponent of using natural supplements like L-arginine. And so if they do start to get some spontaneity after doing the injections for a while, then maybe they would work their way backwards into being a regenerative therapy candidate, like for Gainswave.
What do you see is going to be the next horizon in the battle against ED?
Yeah, great question. So I'm actually really excited about this exosome therapy. We don't have a lot of data on it, but in a nutshell, exosomes are like little bubbles that sit on the cell membrane, and they actually are able to signal different parts of the body where there might be need for repair or need for improved healing. And so it's kind of the body's complexity kind of brought down to these little components that we can use at our disposal in the areas where we need them, such as penile injection, or wound healing, or a number of different areas of chronic disease, to allow the body to kind of signal where it needs help, and it can kind of repair itself. So I think that's definitely a hot topic. We have a lot of knowledge. We just don't always know exactly where to use it. But I think as we get more experience, we're going to find that we have a lot of benefit to help the body heal itself from diseases like ED.
And finally, with COVID, in this pandemic, I saw that study by the University of Rome that shows that 30% of all men that have had a COVID infection are going to suffer from some form of erectile dysfunction. Have you seen an increased number of men who have come to you that have survived COVID and have had problems with erections?
Um, you know what? I did read that article, and obviously it had some limitations because I think some of it is um, uh, it, you're trying to correlate two different uh, and very common scenarios. I think the thing that was interesting was that in that study they were younger men. They weren't men that you would expect to have significant issues with ED. Um, so I wouldn't say that I've seen um, more than what I would expect of guys that had ED that said, "Hey, I also had COVID, and I think that's what caused it." So now that I've read the article, I'm actually looking for a little bit more to see if that is the issue. I think some of it may be also related to the social distancing, um, but the thing that the article did bring up, which we know is a side effect of COVID, is it causes um, endothelial or kind of vascular dysfunction, which is what ED is. And so I'm not surprised by the findings. I just haven't personally seen a lot of it, but I'm more aware of it now, and so I'm going to definitely question my patients more on that aspect, so that I can see if that's I'm seeing that same correlation. But I don't doubt that. I don't doubt that there could definitely be a causative effect just by what we know COVID does to the blood vessels. So
Would Gaineswave be a good treatment for those men?
yeah, I don't see why not. It would definitely, again, these are in that study. It was younger men. Younger men are typically going to do better um, with any therapy, just because they have a little bit more, um, uh, yeah, younger cell activity. But I would say it'd be true for all men, especially depending on where they score in that shim study. So again, if they score single digits, I think it's a little bit of a run uphill. If they're in that mid-teens to low 20s, they're going to be good candidates for regenerative therapy. And Gaineswave, I would say, kind of leads the charge in regards to regenerative therapy.
And finally, I love the term mancologist. How did you come up with that?
uh, I'm trying to remember. I think we were just kind of uh, joking about you know uh, I think my son came up with that.
It's clever.
Yeah,
I've
we were
never.
talking about what we
It's
do.
great.
So. But yeah, it fit, and I said, well, I think men's health has been, I wouldn't say put to the side, but I think in regards to really looking at an integrative approach, I think men are kind of left outside because they typically want a quick fix, and they don't want to necessarily spend a lot of time investing in changing their lifestyle. But I think if we tie it to something tangible like their sexual health, then they're going to be motivated. So if we say, hey, if you do this and this and this in regards to your diet, your activity level, and your healthy choices, then you're going to see this and this improvement in your energy level, your erectile strength, and sustainability. So if we can kind of give you what you want, and you kind of do a little bit of work for it, then it's going to be a win-win.
Thank you so much. I really appreciate your time. Enjoy Idaho. It's quite a move. Well, why'd you pick Idaho?
Oh, so we were kind of researching. So I'm California native. I was born in LA. My wife's from San Diego. We've been in Southern California most of our lives. But as you know, a lot of things have changed over the past several years. We were looking at looking at places that just you know um, that had a kind of beautiful outdoor landscape, a lot of outdoor activity, um, and Coeur d'Alene, Idaho area just kept coming to the top of the list. And so we kind of accelerated our plans, and it just, everything kind of fell into place, and said, okay, let's jump in with both feet. And that's what we did.
I love it. Thank you so much, doctor. I really appreciate your time.
You're welcome.